Hi guys, Dr. Dan Nightingale here, your clinical dementia specialist. Today I want to talk about how we engage with people and attempt to mitigate unwanted behaviour. Unwanted behaviour can come for many reasons. It's very often environmental, and it's very often something that is external to the person. Over the years, we've often thought of people's unwanted behaviour as being part of the dementia process, part of the biological process, organic. Very often it isn't. Very often, as I said, it's environmental. It can be triggered by caregivers, by relatives, by external events. It can be triggered by professionals. There's a number of things that can trigger unwanted behaviours. And very often communication is at the core of it all. So we have done a video in the past on communication, attitudes and response, my CART approach. And very often there can be triggers. I'd just like to give you an example. When I was a student nurse, I was allocated to support this guy to get up in the morning, to get ready, to have a shave and those kind of things. The guy didn't communicate verbally. And I'm green, okay? I'm green. I'm a student. I'm new to this game. And didn't really understand what it was that he was communicating to me. Because I was about to give him a shave. He had an electric razor. And I was going closer to his face to shave. And he was making some sounds and he was pushing me away and pushing me away. And then he grabbed the shaver and he threw it across the room. I withdrew because I didn't know what I was going to do. I withdrew and I went to speak to the nurse in charge, and she came in with a care plan. And the care plan explained that if you do not communicate effectively with this guy, if you're going to do anything intimate, like help him shower or shave, and you didn't give him the opportunity to hold the shaver, in this case, he will get very agitated and frustrated. Who was the cause of that gentleman's unwanted behaviour? What do you think, Lynn?
You were.
Absolutely. And why?
Because you had no idea that there was a set of unspoken rules that you needed to follow, because you didn't do any investigation on your part before you attempted to care for this person.
Right. What should I have done?
You should have let him hold the shaver first.
Yeah, but what should I have done before I even started to engage with this individual? I should have read the care plan. We must always read the care plan. The care plan is there for a reason. The care plan is there to follow. It encourages consistency. It encourages the right approach, the right intervention. I didn't even think to read the care plan. And some people might say, well, you're a student, so your supervisor should have made sure of that. But at the end of the day, it was my responsibility. I didn't do it. I know better. I should read a care plan. So that's just one example of an unwanted behaviour that was caused by me. So there's many other things. We've talked in the past about sundowning syndrome and what we can do to mitigate that. We've talked about transitional shock and what we can do to ameliorate that. So let's really think about how we can reduce the risk of people presenting with unwanted behaviours. And what I have and what I love, and I've used this for years, both as when I was an RN, I used it, and when I was a dementia specialist in the UK, I used it. As a doctor of dementia, I swear by it. And can we see that, Lynn? Is that something we can see on camera?
A little closer. There you go.
This is called an ABC chart. an antecedent, behaviour and consequence observation chart. Okay. Now, you'll see that it's split into various columns. Okay. I'm going to post this with the video today, so you will be able to look at it and see it. Some people who are watching this video will be familiar with it, some not familiar with it. And the whole point of it is to be able to identify why somebody behaved in the way that they behaved. Okay, so it's split into columns. There's the date and the time, obviously, absolutely crucial. And then the rest of the columns are split into 5 things: environment, and then your ABC, and there's a signature column as well. Sorry, so ABC: antecedent, behaviour, consequence, and then a signature column. It is absolutely crucial that you write as thoroughly as possible in this observation chart and put it in positive terms. Okay, it is no good saying Bill threw the cup at Margaret. What does that mean? There's nothing there, is there? So what we need to be saying is, okay, in the environment column, this was in the dining room. Okay. In the antecedent column, we're going to focus on 2 people, right? So we'll have Bill and we'll have John, okay? So the antecedent was that Bill and John were sitting opposite each other in the dining room, and Bill was very agitated at John. That's the antecedent. What was the behaviour? The behaviour was that he was shouting and swearing at his fellow resident, and they got into it. They started arguing. He was shouting back, he was shouting at him, and they got closer and closer, and then he picked up the cup and he threw it at him, and it hit him on the forehead. There's the behaviour. What is the consequence? The consequence is these 2 gentlemen were separated. The guy with the cup that hit the head had a cut, and he was taken into the treatment room and given treatment, and it was dealt with that way. The guy that threw the cup, what do you think happened to him? What do you think the consequences were for him in this case? Lynn, any idea?
They kept cups away from him, probably.
Yeah, they get cups away from him. Yeah. So to put that in positive terms, you would write something like, Bill was escorted away from the dining room into a quiet space. He was given the opportunity to calm down. I explained to him, what you have done is unacceptable, but I can see you're agitated and frustrated, so I would like you to just sit there and breathe and calm down for a little while, and I'm going to go away for 5 minutes. I'm going to implement the 5-minute rule, and then I will come back and see if you've calmed down. And then we can talk about what happened and why. So what we haven't done, is split them up, made them go to their rooms, given them medication to calm them down. We haven't done any of that. We've been very positive, we've been very structured, and that is the way that you would implement this antecedent behaviour consequence. And what you are looking for are patterns of Bill's behaviour, because Bill was the one that threw the cup. So you're looking at Bill's behaviour. Is there a pattern to this? Is there a certain time of day that he gets agitated, that he gets frustrated? Was it maybe just a one-off occasion where John had done something to trigger Bill and these guys had got into it? You know, so you're looking for that pattern. You're looking to identify that. If you do identify a pattern, then this is where you would discuss with people with a multidisciplinary team. So you would be talking to relatives, to families, to professionals, everybody getting together, to Bill as well, and talking about, okay, what is it that we can do to change this pattern of behaviour? And of course, we're always looking for a non-pharmacological intervention. Remember, always a last resort. Medication should be used always as a very last resort, always the smallest amount possible for the shortest time possible, and as an adjunct to other treatment and therapy that is non-pharmacological, that is not drug-based. Okay, so that is a way in which we can be positive and engage with people in an environment that, remember, is very unusual and abnormal. Because when you live in a nursing home or a group home, you live with a group of people that you don't know. There's a group of people you didn't choose to live with. So your environment has changed. It's an environment that we're not used to. Sometimes those environments have locked doors. We don't live in environments with locked doors unless we're in prison. We're not in prison. Why are the doors locked? What do we do about that? We have to lock the doors for the safety of the residents. Okay, I get it. What can we do instead of locking doors in order for people not to go through them? Well, as somebody who I know is watching this video, she and I used to work together in the UK, and we had murals painted on the doors that we don't want people to go through. And we use the right colours. So a colour of red is something that indicates danger. The primitive brain understands that. So you use colours that give you those messages. So we would paint things like bookshelves, a mural of a bookshelf on a door that I don't want you to go through. Therefore, I learned that that's not a door. So there's many ways in which we can help reduce behaviours that are unwanted without the use of medication or without the use of any intrusive interventions like we used to in the past, where we would remove people, restrain people, put people in a separate room, put people in time out, all these old-fashioned things that we thought we had to do, that we don't have to do if we address it in the right way and if we are positive and our body language expresses our openness and our accessibility. So that's what I wanted to talk about today. I will find a way of putting this on the YouTube channel, on the comments section. Okay. So I know Lynn's as you know, Lynn's here with me today. She's always here with me. She's helping me with these things. Are there any questions that come to mind from that?
Who can implement that? Professionals only?
Anybody can do that. You can do this at home. So if you're living at home with someone who is living with a neurocognitive disorder and they have some behavioural issues, you can use this, because whoever it is that you're working with, so you might be working with a neurologist, you might be working with a clinical dementia specialist, you might be working with one of the nurse specialists in the UK, the Admiral nurses, whoever it is you're working with or whoever it is that's supporting you, you can share this with them. And it's a good way of being able to create the right intervention. So anybody can use it. It's not just specifically for professionals.
Can you use it for things other than unwanted behaviors?
This is specifically for behaviour. What were you thinking? And I'll tell you whether or not it could
No, I just
work.
mean where maybe you're trying to find triggers of things that create paranoia in your loved one, or you're trying to find triggers and things that...
You know, these are unwanted behaviours, so yes, you can use it for that.
Okay.
Yeah, documenting how long that incident lasts, documenting what it was. But the key is always to write things in positive terms. Don't be negative when you document. Be positive and specific, because it's really important that you are very specific and accurate about the behaviour so that we can get the right approach and the right intervention.
And what if that doesn't work? What if that tool, if you're having trouble using the tool, what should you do?
Ask somebody to assist you with it, because it's a tool that works and it's a tool that's effective, and it's a tool that's been used in behaviourism for years and years and years. It's a proven method for observation and monitoring and documenting, and then developing the appropriate intervention, the appropriate care plan.
Okay, and if you're a loved one and you're filling out this form for your father or mother that has a neurocognitive change, they may not know exactly what to write, but if they can at least try to document what they're doing, maybe even if what they're doing isn't the right thing to do, or maybe if they're struggling and don't know what to do, perhaps they could still document what they can, what they thought was right that they did, and then talk it over with the neurologist and see if that was the right plan.
Right. Good. Yep.
So they can
That
get
would work.
advice about it.
Yeah, absolutely. And of course, if you're seeing a doctor or a nurse and you're going for a consultation, any kind of documentation and write down any questions that you have, write down anything that is specific to that consultation, because you'll have questions and you might forget them. When you're actually talking to the doctor, some people forget to ask you the questions. They get nervous and they get overwhelmed and that kind of stuff. And then once they've left, they contact the office and say, oh, can I just ask Dr. Nightingale this question, because I meant to ask him when I was there. So write them down so that you get the information, you get the answers, and you get the support that you require there and then. Always a good idea to do that.
And I just thought of a topic for our next video. What are the questions you should be asking the neurologist when you're given the diagnosis?
Good topic. We'll do that next week. Yeah, I have to write it on the board. Let me remember. Okay, cool. Well, thank you for listening to that. It's been useful. I know it's been helpful. I know I'm going to post the form on the YouTube channel. And yeah, have a fantastic week. And remember, say it with me, dump the soda.